guys?
Yeah, I mean, not missing the obvious, this is actually a soft tissue problem rather than a fracture problem. We're actually getting onto these perhaps too late to describe the second injury, but we're always just looking at the bones and the architecture. What about the actual soft tissue?
To be honest, I think that is actually the key. I think that, it's an old saying, long-standing from very wise people, that a fracture is just a broken bone inside the complex soft tissue. And I think that that's true, particularly for calcaneum. And it's not just about the fat pad and the soft tissue stuff that's vaguely around there. It's about alignment of tendons, tendon pulls, the balance of tendons, how they work, how they influence the performance of the rest of the foot. And as I say, particularly wearing a foot and ankle concept, I think that where the forefoot ends up is always critical to what we do in terms of hindfoot fusion. If we get the forefoot in the wrong place, patients are not happy. And they get pain in various sites just simply because of mechanical loading. And that is because of malalignment of joint as much as anything, and that can be radically influenced by the performance of the soft tissue. So I do think it's about management of soft tissue. And I think that may be true, going back to the business about elderly ankle fractures. What do we really know about elderly ankle fractures now? Well, we sort of always know, but now the latest trials have shown us that actually people don't do terribly well when they're elderly and they have an ankle fracture. We have to change that dynamic if we can. We may not be able to, but the same applies here.
Okay, can I also ask about tourniquets? I mean, I don't know, I'm not an attribute ankle surgeon, but how many people use tourniquets to do the procedure you're talking about, either percutaneous or open?
But I think if we went back to that sort of technique picture, which was just a glimpse of how we do it, you'll see that there was a bit of ooze around. We don't use a tourniquet for these.
If you don't.
To be honest, the question always comes up, if you're doing an arthroscopically assisted technique, is that going to create a problem? Actually, it's almost the perfect subtalar joint to arthroscope, because somebody's kindly moved all the bones out of the way. And then you just need to wash it out lots, and actually it doesn't bleed that much. And it's well controlled just by the process of arthroscopy.
I'm not a big fan of tourniquets either. I know Alex can get much support over online. I occasionally put them on, Bill, but they're very seldom wear them up these days. Chris? Sorry, Jane, I'm sorry.
So, for me, the HEAL trial was scientifically valid, and I think clearly demonstrates that in the hands of the occasional surgeon, which is what the trial tested, the results of operative treatment are no better than non-operative treatment. What Ian is suggesting, which I think is an interesting suggestion, is that the results of the hands in experts should theoretically be better than the general surgical population. So my question would be, is this simply a system problem? Should everybody be fixing 1 or 2 calcaneal fractures per year? Or should we actually blanketly say that people doing 1 or 2 should not be fixing 1 or 2 fractures a year? Should we be centralising these systems, the generalists versus the specialists? And this, I think, this is the nub of many of the problems we face in orthopaedic trauma. The low volume, complex injuries being managed exactly where patients want to be managed, near home. I think is a really difficult problem.
Just before you kick off now, can I just from the science of the study, actually those the surgeons, although not experienced in the way that Ian and Bill are, were selected for having considerable experience of heel fractures. So they didn't do a lot, because frankly none of us do, but they were selected to be the guys that actually were in that centre, which were the big foot and ankle trauma centres. They were the ones who did them regularly. So these weren't the...
No, I understand that, but still...
They're not the experts, I know what you're saying.
The most done by...
So do you want this, or you can shout up?
I'll shout.
Okay.
Can I just ask what role, if any, does acute subtalar fusion to the management of your calcium fracture have in your practice or North Bristol?
In those terms, okay, fine, if you take a Sanders 4 type, what we call metaphorically buggered calcaneal fracture, there's good evidence that if you do a fusion, then you're actually using the talus as one of your attachment points to realign the heel to actually do exactly what we're talking about. Get the foot under the load line, get the longitudinal axis of the foot line. So yes, we will do fusions. Do we do fusions by preparing the joint surface? No, we don't, because of the argument that I gave earlier on, is that I think you're just adding to the complexity of the injury. Now, someone like Stefan Rammel will say, actually, he's now routinely just whisking the joint surface up with an arthroscope. So he's just saying, oh, I'll take a bird to it. It'll make it stiffer better. But yeah, I think fusion has a role, and we have to define that role, and in the more complex injuries. But the aim of the exercise, it has to be recognised. We want the heel in its right place to influence the whole performance of the limb and the whole performance of the forefoot. Coming back to Chris's point, I think in a way this aspect of generalisation is actually quite important to recognise, because it's a constant thing. Oh, I'm a real expert, I can get better results than that. But there are some factors that are influencing that. So it's one of the great things, BOA president, woo, I get to see international stuff, and I get to realise what we do here influences the rest of the world, and that's a really good thing, because there is robust science being done. Now, can you apply those principles to everywhere in the rest of the world? And the answer is you can't. So what we then have to answer is two questions going forward. So if we're saying that we think the soft tissue management, the management of that, is influencing even the best produced results, then again that shifts that big posterior lateral incision out of the equation. And then we then have to say, can somebody who does this once a month reproduce it if they're doing it percutaneously, or do you have to be doing it 50 times a year? I have to check the maths. Oh, once a week.
Sorry, we're rapidly eating into Shiva's time. You've got a really important point, Tim. I mean, you always have a really important point.
Is it really crucial?
Yeah, it's crucial.
Yeah, absolutely. So it's in defence of the extended lateral, I think. Chris is right, the diagnosis of the heel trial as a system isn't right, not that we can't do surgery well to the benefit of patients. Ian is right that you have to take apart that subtalar joint in order to get everything else in the right place. So although the cartilage is knackered, and that will never be the same again, it's crucial to do that bit of the jigsaw, otherwise the rest doesn't work. And sometimes you can't do that jigsaw completely without an extended lateral. I think there are some that you just can't get in there. And so my conclusion, bringing those 3 points together, is that you need to have somebody who does that and is able to do that in order to fulfill the criteria that you have a service that can do that safely.
So surgical expertise is important. So hands up all the below average surgeons in the room. It's funny, I've tried this with Belfast and there's no one.
Cruel but fair.
Ian, thank you very much.